Great job on those first two sections. Video 3 will talk about an overview of orthodontics. Let's dive right into dental facial growth and development. So the main concepts for facial growth looks at 3 different measures: face height, face width, and face depth. So this talks about the vertical dimension of growth, the horizontal dimension of growth, or transverse, and the anterior posterior dimension of growth. So from back to front. Now, the main considerations is at what time points these dimensions are done growing. And this is important to know for the development of your pediatric patients. Now, face height is mostly done growing by age 3 and by the almost completely finished growing at adolescence. With the transverse or horizontal dimension, that growth is nearly complete by age 6. And what's interesting is that anterior posterior, that front to back, from the anterior to the posterior, that's the last component to start growing. And now one other important concept, I'll actually direct you to the table on this slide, is this adolescent growth spurt. And it differs between females and males, and where it starts, where it peaks, and where it's completed. I want you to just have general understanding that females will start growing and that growth spurt earlier than males. Now let's talk a little bit about the eruption sequence of the primary teeth. So this is something that you'll track from your baby, youngest patients up to your pediatric patients right before they start developing their permanent occlusion in their adult teeth, where I want you to remember this order here from anterior to posterior in general for maxillary mandibular, where it's relatively in order except for that canine and that first molar. We're going to start with those anterior incisors, then your first molar, then your canine, then your second molar. Now, obviously, there are deviations from this, but this is the general trend for most patients. Now, I want you to look at this really detailed table about calcification, crown development, eruption, root development, and exfoliation for these primary teeth. There is a lot going on here. So let's break it down into big picture concepts where especially for this calcification, you'll see this age range for these primary teeth to be that 4 to 5 month, 4.5 to 6 month range. For crown completion, this really varies between the teeth, so there's a wide range there. And the main area I want you to remember is this eruption. I think this is important, where you're going to see from 2 to 3 years old, all those teeth starting to erupt for most children, those primary teeth. And the first one's coming in at that 8 to 9 month, or even earlier, that 6 to 10 month. And generally, those mandibular incisors can be erupting before those anterior ones. Again, these are all trends, and each patient's different. And then I want you to start looking at exfoliation, where generally those incisors around that 6 to 8 years old age for those first teeth to start to exfoliate, and that's in combination with the eruption of the first permanent teeth as well. And then the remaining canines / posterior teeth that up to around 11 to 12 years old when those exfoliate. So general trends for those eruption and exfoliation. If you can remember some of the specific numbers for the calcification and crown completion, that's good as well. But I want you to highlight those eruption and exfoliation time points. Now let's talk about the eruption sequence of the permanent teeth. And it's interesting, it's a slightly different order for mandibular teeth and maxillary teeth in general. So I'll direct you to these figures here, where for both maxillary and mandibular, that first molar comes in first, followed by those incisors. Now, the difference comes between those canines and premolars. I'll let you take a moment to pause the video and look at those on your own. But the best thing is that towards the end, those second molars and third molars, that's where that tooth eruption generally completes. So looking at what's at the beginning and the end, and then filling in the blanks for the middle for the maxillary and mandibular arches will be helpful to remember that. Alrighty, another table, and with these adult teeth, that's a little bit more involved. So I've split this into two different slides. So looking at the maxillary teeth, let's take a look at this table at the calcification and crown completion. Those are good to know, but I'll direct you to focus more on the eruption. So with those first molars and those incisors coming in first for this maxillary arch, the main difference, those canines and premolars, those come in around that 10 to 12 years old, and it differs between the mandibular and maxillary arch. Now, same idea with these mandibular teeth. So you got the calcification and crown completion here. I want you to know those general vague ballpark values, but focusing here on the eruption in years with those incisors, that permanent first molar, followed by those canines, premolars, rounding out with that second molar and third molar. Great job on those tooth eruption and development. Let's talk a little bit more about growth patterns in the context of dental facial growth and development. So there's 3 broad growth patterns. You're basically categorizing people into 3 big picture buckets. One is brachiocephaly, mesocephaly, and dolichocephaly. So these are 3 different overall growth patterns that you can start to identify, and it helps you with diagnosing and coming up with overall big picture where your patient is at. So with brachiocephaly, the main consideration is that this is a more horizontal growth pattern with that flat mandibular plane angle and a broader, wider face, and that includes broader, wider dental arches, and generally with a tendency for a deep bite. So this picture right here shows all of those characteristics. Mesocephaly is more of that like average balanced growth pattern. It's not too wide, it's not too narrow. Whereas dolichocephaly, that's a more of a vertical growth pattern, a steep mandibular plane angle, a tall, narrow face with narrow dental arches with a tendency for an open bite, as you can see right here. So you can see that mesocephaly is right there in the middle, with brachiocephaly being more wide and deep, and then dolichocephaly being more narrow and vertically open and longer. Now let's talk a little bit about occlusion and the transition from a primary occlusion to permanent occlusion. So just a quick review from our occlusion section. I'll have you take a look at these figures here where we can characterize our permanent occlusion as being in class 1. So again, we're looking at that mesial-buccal cusp tip of the maxillary permanent first molar and where it falls with that mandibular first molar, that buccal groove. So with that class 1 relationship, that's right on sort of that quote-unquote normal occlusion. When you have that mandibular molar more anterior, more mesial, that becomes that class 3 permanent occlusion. You can have an end-to-end occlusion where those cusps are slightly more distal, but not quite class 2. And then when that mandibular permanent first molar is more to the posterior, more to the distal, you get that class 2 occlusion pattern. And this is all dental occlusion classifications. Now, let's connect that to our pediatric occlusion, where there's actually tendencies, depending on where you start with your pediatric occlusion, where patients may end up with their adult permanent occlusion. Just think of that. This is one of those areas that you can take a crystal ball and predict the patient's occlusion in the future. Again, not perfect, but still pretty good in terms of having a general idea of where your patient's growth and development will take them. So let's consider the mesial step. We can consider that kind of like the class 1 for a pediatric occlusion, where we're looking at where the primary molars are, and you can see that with starting in a mesial step, so this is the furthest back, you're looking at the primary second molars. If you can see that there's that mesial buccal cusp of the primary second maxillary molars aligning with that buccal groove of that mandibular second primary molar, that's more of that mesial step occlusion. And those patients will tend to develop into a class 1 permanent occlusion or even a class 3 permanent occlusion. Now, looking at that flush terminal plane, we look at that most posterior molar, that primary molar, so where those second primary molars are, and that most distal surfaces of the teeth are aligned and almost flush. Those patients with that occlusion pattern in the primary pediatric occlusion will most likely end up in end-to-end occlusion or shift to a class 1 occlusion, depending on how their growth will develop. And finally, with that distal step, that's where that primary second mandibular molar is more distal to that maxillary second primary molar. And those patients will tend to grow into that class 2 relationship or an end-to-end relationship. So that's an overview of how you can use that pediatric occlusion to predict a permanent occlusion, and a quick overview of both types of occlusal classifications. Now, moving on, let's talk about some definitions and some specifics to the pediatric occlusion. So one concept is the primate space. So the primate space, I'll have you take a look at this figure right here, where it's the interdental space between that primary maxillary canine and that primary maxillary lateral incisor in the maxillary arch. And in the mandibular arch, that space distal to the primary mandibular canine, and that's mesial to that primary mandibular first molar. And so there's that extra space there that helps with that eruption of those permanent teeth. And we have this concept called the early mesial shift as that primary occlusion, that pediatric occlusion is developing as the patient grows. So this is what that primate space looks like in the pediatric occlusion with just primary teeth. But here you can see as that first permanent molar erupts, those eruptive forces encourage that mesial movement of these primary molars to close that primate space. So that's called the early mesial shift, the early mesial shift of the primary pediatric occlusion. So that closes that primate space that's present. All right, you guys are doing great so far with these definitions. Let's talk about leeway space. So leeway space is that mesiodistal size difference between the primary canine and the primary molars with their permanent successors. So there is some built-in space where you have those permanent successors are smaller than the primary teeth, and that gives some space for that occlusion to develop. And now there is a second concept that's called the late mesial shift. So I'll have you look at this image right here, where we have this definition of the late mesial shift, and that first permanent molar continues to shift mesily into that leeway space after that second primary molar exfoliates. So this image here shows how much leeway space is present here. You can see that comparison between those primary molars in canine and the permanent successors, the permanent premolars and the permanent canine. And then there's that additional space from that first permanent molar shifting mesial and closing that space. So that's called the late mesial shift, in contrast to that early mesial shift that we just talked about. So this is a quick overview of that early and late mesial shift. So you can see in both situations that permanent first molar driving that shift in both arches and utilizing that primate space here in the early mesial shift, and later utilizing that leeway space in that late mesial shift. So now's a great time to take a break to do a review question. Great job so far. Alrighty, great job on that question, friends. Let's finish up this video by talking about the orthodontic pre-treatment assessment. So an overview of the orthodontic pre-treatment assessment, we can actually utilize a very similar approach to our history and physical exam that we talked about for the pediatric patient. So the overview, you really want to look at the chief complaint, what's bringing the patient in the context of this orthodontic treatment planning and assessment. doing a full medical, social, dental history, and completing that objective clinical exam and any radiographs that are needed, and completing the diagnosis with taking photographs, study models, and doing space analysis, and really determining the overall picture of the occlusion in the patient. Then coming up with that problem list and diagnosis and a treatment plan to tackle it. So let's talk about some of the components of the pre-treatment assessment, and then some specifics that can be applied in the context of orthodontics with each of these components of the pre-treatment assessment. So looking at the chief complaint, making sure that you address what's the reason that brought the patient in. There are some considerations with the medical history, such as special healthcare needs or even some history of chemotherapy, radiation, bisphosphonates. These can impact the orthodontic treatment that you can provide and when you can provide it. Now, the social history, you need to understand who the patient is and where they're coming from, and especially their dental history too. Any history of trauma, and making sure that they have very strong oral hygiene habits to be able to start orthodontic treatment. Because if those habits aren't there, that foundation isn't there, starting orthodontic treatment can cause harm to the patient. And then with the extraoral exam, making sure you consider the TMJ, doing profile, frontal analysis, facial analysis, all those components that we talked about earlier, understanding who your patient is and diagnosing and documenting those considerations and characteristics. Overall, looking at facial profiles, this is one area that you can do in part of the extraoral exam. There are three main considerations for facial profiles, and overall looking at a more convex profile is one aspect. A straight profile is another type of one of three categorizations, and a concave profile. So understanding where your patient is starting can also help you come up with that best plan for the patient. Next, moving on to facial proportions, you can consider facial proportions in the vertical space. So looking at different anatomic landmarks to see if overall, if there's a balance in these vertical dimensions, whether their dimensions are divided evenly in these facial thirds based on different landmarks, or if there is some differences in that patient and how that can influence the aesthetics and overall result that you can get. Another consideration for facial proportions is actually the horizontal or transverse plane, looking at the facial fifths and looking at different anatomic landmarks to determine if there's relatively equal horizontal fifths or there are some differences in those distributions of the horizontal space. Now we'll continue with that pre-treatment assessment, looking at the intraoral exam. So we've looked at everything about the patient from the outside, both history-wise and extraoral exam. Now looking at the shape, the health of the soft tissue, looking at the teeth, again, looking at health, shape, number, and then the occlusal relationship, so between the teeth and how the jaws relate. And there's some additional diagnostics that we mentioned earlier by taking any radiographs and additional views such as lateral cephalograms or panoramic radiographs, CBCT, and additional study models, photographs, and analysis like space analysis. And you can use all this data to then come up with your problem list diagnoses and a treatment plan to address the patient. Let's dive a little bit into that space analysis that we mentioned. So space analysis, what you're looking at is to determine if there is adequate space or insufficient space for a patient. And this is especially important for pediatric patients with that developing occlusion. There's some tools that you can use to predict by measuring either the current primary teeth that are there or some of the permanent teeth that have erupted to then see how much space there will be, most likely, for the permanent successors. So one approach is the Tanaka-Johnston space analysis. So we have right here step-by-step a formula that you can use to calculate this measurement. And I'll give you a moment to read through this and have the big picture of the approach, and then we'll do some examples on that as well. The second approach is using a Moyer space analysis, where you're basically using a prediction table to come up with the space required for unerupted canines and premolars. And these are just two different approaches that you can utilize for space analysis. So another component is cephalometric analysis. So this is where you utilize a lateral ceph radiograph and then look at certain landmarks to determine different measurements and areas of either excess or deficiency and the sort of distribution of these landmarks. And here I've included some key cephalometric analyses that are some main takeaways from these lateral cephs. I won't dive too much into it, but these are here for your reference in the table on the slide, looking at different points and how they can predict certain facial characteristics or associate certain facial characteristics. All right, great job with video 3, looking at pre-treatment of orthodontic assessment and examinations and considerations for the pediatric patient and also patients in general for orthodontics. Take a step back and look at some of the tables that we went through and maybe take a second look at that space analysis. Try and come up with some examples and walk through that step by step to calculate some predictive measurements and values. You guys did a great job. Let's finish strong with this last video for the pediatrics and orthodontics section.